Hello, my name is Carrie Donahue. I'm the Associate Director of Grassroots Advocacy at the Crohn's and Colitis Foundation. Today, I'm joined by IBD patients and caregivers, as well as my advocacy and education colleagues, to talk about navigating insurance denials for IBD treatment. Unfortunately, insurance denials are a challenge that many IBD patients face regularly. In 2021, insurers denied an average of 17% of in-network claims, totaling about $48.3 million. Denials are increasing, while insurers sometimes fail to even look at the patient's medical record. For instance, we've learned that one very large national plan uses a computer system that automatically denies 300 claims per minute. And consumers very rarely appeal denied claims. Only 0.02%, or 1 in 500, were appealed in 2021. Some patients don't even know that they can appeal these denials. However, there is hope. The good news is that if you know how to appeal your insurance denial, many appeals are decided in favor of the patient. So we want to talk today about these denials and about how you can make progress in turning your denial into an approval. And we'd like to thank Takeda and Janssen for supporting today's panel. First, we're joined today by Ava Hosey and her mom, Sherry Thomas. Ava is an IBD patient who's going to share her story of an insurance denial. She's here with her mom because we know that denials affect the entire family. Thank you, Ava and Sherry, for joining us, and I'll pass it to you to share your story now.
Hi, my name is Ava Hosey. I'm a 19-year-old IBD patient, and this is my mom / medical manager, Sherry.
Hi.
I was originally diagnosed with ulcerative colitis 4 years ago. Even though the pathology of my illness clearly indicates colitis, getting approval for any medication, procedure, or supply that doesn't clearly fall under colitis protocol is denied. Being denied for medications and supplies has become so commonplace for us that my mother and I are both genuinely startled when there isn't some sort of holdup. There are many things that seem to trigger insurance denials for my medications and supplies. First are step therapy-inspired denials. Our initial experience with insurance denials happened behind the scenes with the selection of my first IBD medications. We had no idea at the time that insurance companies were steering doctors away from more effective medications to minimize their costs. Denials brought on by step therapy protocols required me to try and fail several low-cost IBD medications. Wasting time with these medications worsened my colitis, so by the time I received a more effective but more expensive medication, my disease had become so severe that I required a loop ileostomy surgery. This inadvertently worsened my colitis and my overall health. The colitis inflammation that worsened during this time also resulted in excruciating perianal complications, the inability of surgical wounds to heal in that area, chronic anemia from daily blood loss, and reliance on narcotics for pain. Medications delays caused by insurance denials ultimately resulted in a 7-month hospital stay and complications that still remain unsolved. I'm fairly certain that my time in the hospital, which included 2 surgeries, cost the insurance companies more than a more effective medication would. In addition to step therapy-related challenges, there are several additional areas involving insurance denials that have been problematic for us as well. Second are denials due to annual insurance renewals. Another part of the denials process that has been particularly challenging for us stems from the fact that insurance company annual renewals and carrier charges will ignore a patient's approval history from the previous year. Under my insurance, all patients become new patients again, which may not be problematic for healthy people, but chronically ill patients are affected disproportionately as repeated denials and appeals disrupt critical continuous care and cause undue emotional stress to people already going through physical duress. All the multiple appeals we had to go through initially, all the time and energy spent by both my family and my doctors become meaningless once the new insurance year begins. Each year triggers a series of denials and appeals for medications and supplies I've been using for 4 years. Step therapy protocol also makes an appearance during these denials, as my insurance carrier constantly tries to put me back on the same inexpensive, ineffective medications I first tried 4 years ago. And while new safe step legislation is expected to improve this, the process currently remains time-consuming. I don't know what this looks like for other IBD patients, but for us, the average resolution time for insurance denials has been 5 to 6 months before we can stop making telephone calls and my ongoing orders are correct. Not having consistent access to my needed medications and supplies results in repeated health setbacks and visits to the ER and urgent care. In addition, the stress of this annual ordeal and of having to go without critical medications and supplies for several periods of time per year puts me and my entire family on edge for months on end. When a patient moves their care to a new doctor, all their medical files are sent over to ensure a smooth transition and avoid disruptions in care. It seems like this should also be the standard protocol for insurance companies, but sadly it is not. I think it's important to know that although I am fortunate enough to have a caregiver to help with the cumbersome denials process, there are many young people with IBD whose family members don't have the time or energy to haggle with insurance companies, suppliers, and even doctors who are too busy or understaffed to help with the appeals process. When some of these patients get kicked off their medications and have no help, they are forced to cut out the middleman and go to the ER every time they need their medical infusions. The denials process seems to magically fall away in the hospital. I'm assuming this is so insurance companies can minimize inpatient hospital costs. Some IBD patients who run into repeated challenges with their insurance companies have learned that the only time they have any negotiating power is from a hospital bed. The behavior insurance companies are inadvertently encouraging here obviously represents a lose-lose situation. The patient needlessly suffers and the insurance company loses money. In addition to step therapy and insurance renewal denials, there's an entire subcategory of denials having to do with unique medical needs. My family and I have learned the hard way that the more complex or unusual a patient's needs are, the more painful and time-consuming the insurance process will likely be. This means that some of the sickest people in our country also shoulder the greatest emotional burden of defending their medical needs. Having to deviate from standard product amounts and usage parameters has caused us a lot of headaches. First, product quantities that exceed the standard amount for your medical condition will cause a denial. For example, I put medications or feeding tube into my distal stoma 2 times per day. This requires 2 ostomy pouches per day, which is 60 per month. The insurance-approved quantity for ostomy pouches is only 20 per month. This prescription gets denied every year and has to be appealed several times. I have been shorted ostomy pouches so often that I've had to make them using Ziploc freezer bags and medical tape on more than one occasion. Take my word for it, it's even grosser than it sounds. Second, medical supplies that aren't used in traditional ways will cause a denial. For example, I use feeding tubes and syringes to pump medications into my colon via my distal stoma. The supplier denies these with every monthly order without fail. When we call, we are told insurance has rejected it. It gets kicked out every month because it is only approved in the system for its initially intended use, which is for patients who require enteral feeding. For every monthly order over the last 4 years, my doctor has had to repeatedly send all the supporting documents to appeal it. This year, things got even worse when my insurance company changed my carrier to one that is not an approved vendor for my usual tube supplier. My insurance company offered up an approved medical supplier list, but only one supplier on this list actually carries feeding tubes. This supplier refused to fill my prescription, however, because being in their enteral feeding program is a requirement for being able to place orders from them. My family offered to buy the tubes and was told they could not. My family is now paying out of pocket for feeding tubes from an online supplier, but they are not sterile tubes like those I am accustomed to using, and I'm always worried that they might increase my risk for infection. In addition to disrupting much-needed care, insurance denials for alternative medications and supplies punish medical professionals who think outside the box in terms of finding solutions to improve patient health outcomes. My colorectal surgeon recommended using Urijet as an alternative treatment to help relieve my perianal pain and reduce my narcotic intake. However, because Urijet's primary purpose is to manage urethra pain, my insurance denied it several times. This is another medication that my family ends up paying for out of pocket due to insurance denials and the lengthy appeals process they create. Third, medications that are compounded will also cause a denial. The most effective medication I use is a short-chain fatty acid mixture. It comes in liquid form that I pump into my distal stoma. Because it's a non-pharmaceutical that needs to be compounded, it is often denied and requires a lengthy appeals process. Also, each of the 4 ingredients have to be approved separately, as well as the enema bottles that the mixtures come in. The insurance company constantly tries to apply step therapy protocols to get us to change the individual ingredients to less expensive ones that have nothing to do with the ingredients needed to make short-chain fatty acids. After an appeal, they might approve one of the ingredients but not the others. Once, after several appeals, they finally approved all the ingredients and denied the enema bottle. It is a constant battle. Fourth, when a doctor prescribes 2 or more IBD medications to be used concurrently, New medication add-ons that don't follow step therapy protocol will also cause a denial. When an IBD patient cannot reach remission with one medication, a common strategy doctors will employ is combining 2 or more medications. However, these additional medications must go through the step therapy filter, which requires patients to fail on one less costly, less effective medications first. Even though I've already gone through step therapy to get the most powerful medications I'm on now, the additional medications my doctor wants me to take have been denied because my insurance company told us I need to start with the low-cost medications that didn't work on me way back when this all started. My doctor has been working on this appeal since October. Obviously, everyone's situation is different, and these are just some examples of the challenges we've been experiencing. In all of these examples, hurdles designed to favor insurance companies make it difficult for patients to get back to being well. In my case, the process has resulted in continuous physical setbacks, surgeries, and hospital stays. In addition, the stress brought on by the denials process continues to create undue emotional duress for me and my family. Although the medical challenges might be unique, my experience with the denials process is not. Fellow teenage IBD patients I connect with regularly report similar frustrations and negative health outcomes. Thank you.
Wow. Well, thank you, Ava, so much for sharing your story. I'm sorry to hear of the challenges you've had to deal with, and I can't imagine how frustrating this has been for you and your family members, as well as your doctors and medical team as well. So your story really is a powerful one, and I know it will help others to hear about your experience and how you've navigated this process. So thank you again for sharing this with us. Sherry, we know that this doesn't just affect the IBD patient, but the entire family as well, as Ava highlighted throughout her story. As her mom, can you tell us a little bit more about how this affected you or other members of your family?
Sure. I think the biggest thing is if I'm always on the phone going through the multiple appeals processes between insurance, suppliers, the doctors, trying to bring everyone together to make it all happen. I can't be there for Ava. She'll have a clog in her ostomy. I can't be there to help her lavage it. I can't be there for my family, the rest of the family. If we're at the hospital for months on end, I'm not taking care of the rest of the family at the home. And if we can't get coverage on a lot of medications, then it puts an additional financial burden on the family, and that creates stress. So it just seems to create a lot of stressors for the family, and her not being well yet. I mean, it's hard to sleep when your child's not well still after 4 years, and people are just making it harder.
Yeah, well, thank you so much for sharing that. And Ava, we wish you all the best in your continued recovery. I wanted to ask, can you share what you see as the biggest takeaway for other IBD patients who hear your story?
Yeah, I think the biggest takeaway is that navigating the current denials process is by design not easy. So patients and their families need to remain vigilant and tenacious to ensure they get what they need, which shouldn't need to be the case, but unfortunately it is.
Well, thank you so much, Ava and Sherry. We really appreciate you both sharing your experience, and we know it will help others. So thank you. Now I'd like to introduce Scott Zweigel, who is also an IBD patient, to share his perspective on this. Scott has been active with our advocacy efforts as well as with the Georgia chapter, and he has some helpful tips to share with you about navigating these denials. Thank you, Scott.
Thank you, Carrie, and hi, everybody. Thank you for taking your time to watch this forum webinar. As Carrie said, my name is Scott Zweigel. I am an attorney by trade, a commercial litigator with the Atlanta office of Bradley, Arant, Bolt, and Cummings. I'm also an IBD advocate. I've served on the board of the Georgia Chapter Board of Trustees for about 6 years now, and I'm just rolling off a 3-year stint as president of the Georgia Chapter. More to come after that, but also help with advocacy efforts however I can, because the Crohn's and Colitis Foundation, and they're not paying me to say this, does a great job of advocating on behalf of all our constituents and those dealing with Crohn's, colitis, IBD generally. As a lawyer by trade and a Crohn's disease patient for almost 25 years, I am either fortunate or unfortunate, depending how you look at it, to know a lot about insurance coverage issues, insurance laws, treatments for IBD, and navigating all of it. Having been personally on Remicade every 6 weeks for about 23 years now, I've worked hard to keep my Crohn's under control and know that that works for me, but it also means that I wear battle scars from dealing with insurance companies to try to stay on the biologic that I know works to keep my Crohn's disease under control. Whenever there's a change in insurance or annually, when there is a renewal of the prior year's authorizations and those inevitably get rejected, the process starts all over. And as you heard previously, persistence is what matters. And keeping at it and not taking no for an answer is very important when you're trying to get on the medicine that your doctor wants you to be on. Because you would think that an insurance company would see a 20+ year history of a medication working and approve it. But then again, you're watching this forum or webinar, so you likely know that's not the case. It's something that most folks who have IBD have to deal with in some form or fashion, particularly if you're on one of the more expensive medication. As you may have heard before, a staggering 17% of in-network claims for IBD medications are denied. And that's a frustrating and unacceptable number. So hopefully some of my tips you'll be able to use to get a denial turned into an approval yourself. I think it's frustrating to know that, at least in my mind, a medical decision should be made between a doctor and a patient. But medicine is expensive, and insurance companies are just that. They're companies. They're there to make money for their shareholders and for their businesses. So one way that they do that is to say, well, we're not just going to pay for something that is expensive, and they'll rely on the fact that most people don't chase a denial, and most people will take no for an answer and move on to the next thing. But if you're persistent and you're tenacious and you don't do that, I'm here to tell you that you hopefully will ultimately get an approval for the medication that you actually need. And we can fight back against the insurance company's model to deny certain claims and actually get what both your policy and the law allow and provide for. So just to kind of walk through a few tips on how to navigate the insurance denials, which unfortunately is a process that happens a lot, as I mentioned. First, and it should go without saying, but that's only because it's what I do for a living, but you need to read your policy. You need to know what your insurance policy says, what it covers, what it excludes, how that coverage and the exclusions work, and also what your rights are in the event of a denial. What can you do if you get a denial? Who do you call? Who do you talk to? All of that is very important, and it's written in your insurance contract. And because the insurance policy is a contract, your coverage fight will ultimately come down to what's in the policy. And my guess is if you look at the language closely enough, you'll see that whatever you're trying to get either should be or is covered based on an interpretation of the policy language. Now, I recognize that an insurance company has a big advantage because they have whole teams of people that do nothing but look at these contracts, draft these contracts, know what's included. But at the same time, there's no better advocate for your own health than yourself. And if you understand what's in your policy and you're able to point to specific language and specific processes that are in the policy, your chances of getting a denial overturned go up tremendously. To that end, and I guess the second tip would be communicate with the insurance company about the policy. Ask questions. Ask the insurance company to send you the documents they use to make the decision or the denial. Ask the insurance company what specifically they considered. Ask the insurance company whether they considered, for me personally, my 20+ year history of this particular medication working and my doctor's letters that say it's not worth the risk, even if small, that changing to a different biologic would cause. These are specific little facts that you can take to talk to the insurance company to help them do the right thing and get an approval for whatever you're on. You should also ask the insurance company to give you information about the policy. Oftentimes, they're looking at talking points or stuff that's in the system, and it doesn't marry up with the specific policy that you have. If you read your policy, you can point that error out to them, and you can make hay out of it, and you can oftentimes cause the insurance company to realize that they're doing the wrong thing if you point these things out. So if you have questions, make sure you ask them. And if you don't get an answer, you have to continue to ask until you get a acceptable answer, whether that means calling and talking to a different representative, whether that means going to an escalation department, whether it means, taking what's kind of a meme today, but asking for a supervisor and getting somebody who actually knows what they're talking about to answer your questions. You should press all of the buttons and not be afraid to ask until you get the right answers. And perhaps most importantly, when communicating with the insurance company, take detailed notes of all your conversations. You can use these notes later in drafting letters and communicating with the insurance companies, or, if necessary, bringing an action to court to try to get the insurance company to do the right thing. All of your notes can be used as evidence in those fights to say, look, I talked to Joe on December 5th at 1:00, and it was an hour-long conversation, and he said X. All of that stuff is very helpful in talking about an insurance denial with the next person. So write down when you called, how long you were on the phone, what the representative told you. And I personally like writing down quotes that are helpful to me, because oftentimes, especially after you go through your whole spiel about this is what's happened to me, you might get a representative that is sympathetic to your cause and might say something outside of their script. All of that is very helpful in trying to get a denial reversed moving forward. Also, if somebody says they're going to call you back, hold them to it. Ask what number they're going to call you back from. Add it to your contacts so you make sure you don't miss the call. Ask when you should expect a response. And perhaps if you get lucky, you can say, what is a good callback number, so that when inevitably somebody doesn't call when they say they can, you can get to the right person. So if you have that, and a lot of insurance companies have escalation departments or supervisor lines that they don't give out freely, but if you're persistent enough, you can get that, and then you can continue to talk to somebody and be the squeaky wheel to try to get the right thing that happens, or try to get the insurance company to do the right thing, excuse me. And it requires multiple calls. It requires talking to representatives. It takes getting hung up on multiple times mysteriously. It takes repeating the same story over and over again. But again, be persistent. That is what it takes. The insurance company is banking on the fact that you're not going to do that, and they're going to save money if you don't use all of the tools in your toolkit. So the response is to use all the tools in your toolkit, use all the arrows in your quiver. These are medications that are necessary for you to live your best life. Remember that you have more of a dog in the fight than the insurance company does. So do whatever you can to try to get an insurance denial reversed. Third, you've got to know kind of what the appellate process is for your insurance denial. And that sometimes comes from the policy itself, and it sometimes comes from state law. So not only should you read your insurance policy, but also be familiar with your state law on the insurance code, what your state insurance code says in your state law, what it says about appellate process. Does it allow you under the law the opportunity for an automatic right to appeal, or an automatic right to another level of appeal? All of these things are very helpful, but not a lot of people use them. And again, the insurance company is counting on the fact that you're not going to pull all the strings that you need to pull. And also, as you might hear later, or you might be familiar with, step therapy is a big issue with IBD population. And a number of states, thanks in large part to the advocacy efforts of Crohn's and Colitis, the Crohn's and Colitis Foundation and Crohn's and Colitis patients, a large number of states have step therapy acts that provide legal barriers so that the insurance company can't deny you based on step therapy reasons in certain circumstances, or they have timing and triggers for if you were denied for a step therapy reason, your doctor or you can request a reversal of those denials, and the insurance company only has a limited time period to act. Now, in my experience, because I know what the state law says and what the exceptions for a step therapy protocol is, I am very careful to use the magic words in every conversation that I have. And I'm very careful to tell the representative that they have, let's say, 48 hours in an urgent situation to approve my medicine. Inevitably, the insurance company will very likely miss those deadlines. That only helps you later, right? They're not going to act in the time period. They're going to give you multiple fax numbers, and the left hand at the insurance company is not going to know what the right hand is doing. And you're going to be very frustrated by the fact that they're not doing what state law requires. Well, continue to use that as a mechanism to try to get the insurance denial overturned. So review your state statutes governing insurance policies and don't be afraid to use them. Too often, patients will use an insurance company determination without being fully aware of their rights. Also, and in your denial, it likely says this, but you haven't read all the way down to the small print. Most states have insurance commissioners or other agencies that are tasked with overseeing compliance with the state insurance statutes. These statutes and these agencies often provide protections to patients. Don't be afraid to use them. Call the insurance commissioner. Tell them what's happened to you. Sometimes the insurance company will get a ping from an insurance commissioner or an agency in a certain state, and that's the catalyst needed to get your denial turned into an approval. So, most importantly, make sure the insurance company knows that if they don't provide the coverage, you're going to be stubborn and you're going to do everything that you can to make sure that you get the medication that is owed to you. I think that's my wife says is one of my both best and worst qualities is the persistence and the fact that I'm going to be stubborn. And because this medicine has worked for me for 23 years, if the insurance company tries to get off of it, instead of switching to something else, which then means I'm on that something else, I'll get sick to show the insurance company that they're the ones who are preventing me from getting healthy, and it's going to end up costing them a lot more money. So you can be stubborn, but use all the tools available. And then I would say the last kind of tip, which is multiple tips, is to use the professional help that's available to you. Your medical professional, your doctor, they're there. They want to help. They've dealt with this situation with a number of patients, but they also deal with the insurance issues from a numbers of patients and might be overstaffed and might not have the time to deal with your issue. But be persistent, be the squeaky wheel, call, be polite, ask for more information, hold them to what they should be providing to you. Give them information to help with the insurance denial, right? Because doctors oftentimes can be the linchpin of getting a denial reversed. Ask them to take the time to do a peer-to-peer with the insurance companies. Ask them to submit a letter that details why it's necessary for you to be on a particular medication. Help the doctors with dates, numbers, information that you provide to the insurance company and they provide to you. All that stuff is very helpful in the appeals process. Because keep in mind, it's essentially a war of attrition. The insurance company is trying to wear you down as much as possible. Don't let them. You have to use all the tools in your toolkit. And I keep saying that phrase, but be persistent because that's the way that you're going to get a denial turned into an approval. In addition to your doctor, you also likely have through an employer or through an HR department, through a benefits administrator, folks who A, want to help, and B, it's their job to help. So you can talk to the insurance company on your own behalf, and at the same time have others working for you too, to say, this is Scott. He's been on this biologic for 23 years. It has worked for him. Here's the concern and the risk that we have in the event that he has denied this particular medication. Or, if I'm particularly stubborn and in a particularly long and dragged out fight, Scott is getting sick and missing work because you are denying him medication that he's entitled to and his doctor wants him to be on. So there's folks like your employers, your HR department, benefits administrators who are there and want to help. Also, talk to peers. Talk to others who you may know have IBD. They've had similar fights and they may have tips and tricks. They might have the right number at the insurance company to call that helps move things forward. In addition to the doctors, your work, your peers, you can also reach out to manufacturers. You can reach out to folks like Janssen who makes Remicade. They have literature that describes why perhaps the medication should work for you in this circumstance and why something different might not work. You never know what resources they have. Take advantage of those resources and use them. And then Finally, the Crohn's and Colitis Foundation has tremendous resources and a staff that's there and wants to help and is willing to assist. And the fact that you're watching this means you're likely already aware of the resources. Don't be afraid to use them. They're tremendous, and you should, and it'll help you get a denial turned into an approval. So in sum, there's a lot of things that you can do, but remember, you are going to be your own best advocate for getting a denial overturned. And do whatever you can. Be persistent, be tenacious, be vigilant, be your own advocate, and don't take no for an answer. Thank you.
Well, thank you so much, Scott. These are very, very helpful tips and a lot of great points that you made. We just really appreciate you sharing your perspective on this. And I think these tips seem to clarify what can seem like a really very complicated process to navigate for IBD patients. And I just think it will be so valuable for other patients to hear from you. So thank you. And I'm hearing from your perspective that persistence is key. That's what I'm seeing as the biggest takeaway from what you shared. But I'd like to know what gives you the most hope when it comes to this issue of insurance denials?
That's a great question. I think the hope is that people can take some of these tips and look at me and look at the fact that I've been able to maintain the same medication for 23 plus years after countless fights, and know that there is hope available. Know that despite all the frustration, despite wanting to pull your hair out, despite knowing that what an insurance company is doing is completely wrong, there is a light at the end of the tunnel. And if you take advantage of what the policy says, what the law says, the different layers of appeal, ultimately, if it's the right medication and you're able to persist, hopefully you can get an approval. So, I think what gives me the most hope is there are folks who have done it and done it well, and there's organizations like the Crohn's and Colitis Foundation who's out there to provide the resources to say, hey, here's what we need to help to get you on the medication that you need. Also, one other tip, and you can see the bulldog here on my desk. That's because of my sports fanatic fandom for the University of Georgia, but it's also a good lesson. Be a bulldog. Don't take no for an answer.
It's a really great point. Thank you so much, Scott. We really appreciate this.
Thank you.
Now I'd like to introduce Catherine Soto, Associate Vice President for Patient Education and Support at the Crohn's and Colitis Foundation. Catherine will talk more about resources for patients who face these denials. Thank you, Catherine.
Hello, my name is Catherine Soto, and I'm Associate Vice President of Patient Education and Support, and I'll be discussing resources to help you navigate insurance denials today. So the first thing that I want to point out is that in order to manage some of the struggles and challenges that can be a part of the IBD journey as it relates to getting access to the care that you need, we have, as we're hearing, it can be a struggle to appeal denials, and there's a lot of need for self-advocacy in that process. And so one of the first things that we believe every patient and caregiver of an IBD patient should do is to inform yourself. And you can do this through understanding the different terms that relate to insurance, medical insurance, and coverage. I think that that's going to be an important step to help equip you properly with the steps that you may need to do, and understanding some of that terminology that may be thrown back at you as you're discussing your needs and advocating for your care with insurance companies. And so the foundation does have a suite of resources to help equip you in that way. We have on our website information and introduction to key terms that you should know. We also have video testimonials of patient experiences as it relates to insurance appeals and denials that patients have experienced and how they might have navigated that. Sometimes there are some unique ways that people have managed that, or other times it shows kind of the persistence that is needed. So hearing from other patients is always helpful. We also touch on those complex issues as they come up, so you can come back to our website as we're hearing updates as it relates to policies around access to care. We often do educate patients on our site. Currently, you may see information about what was copay accumulators and maximizers, But we do want to point you also to the steps that you may need in appealing denials. So we do have a section on our website that does help provide some tips and helpful feedback for you as you navigate through that difficult process. We also have helpful assistance programs that are available to patients, whether that is trying to get access to programs that may cover the cost of medications, procedures, or other supplies that may be needed as an IBD patient, or ostomy patients often need the assistance as well. And that is available. While we do not provide them directly, we can guide you to find resources that are available for you to benefit from. And then there are educational videos, infographics, and more. We develop resources that meet the needs of our learning style of different patients. So to access these great resources, we recommend you go to our Managing Costs of IBD section of our website. You can just type that into our search tool on our website, and the name, the program, and the web page should pop up for you immediately. In addition, one specific resource I do want to additionally highlight are our appeal letters. Appeal letters are a very useful tool to help appeal denials and decisions through your health insurance company. And these are tools that are often used by patients, caregivers, and healthcare professionals as well. The tools available on our website, these letters, are meant to be templates that can be customized and do need to be customized to reflect your own direct and individual needs. However, our tools and our letters have a basis for some of the common reasoning behind medication dosing appeals, prior authorizations that may be needed for specific medications, letters to appeal for access to certain tests and procedures, and there's several others on our website as well. I know that there's one more specifically around accommodations that people may find needed in the workplace or in other settings. But I think these are a great place to start if you're looking for a way to appeal a decision and need a basis for that. We do have some of those templates available. I want to stress what you may be hearing here as well through this program is the need for partnership with the healthcare professionals. Oftentimes our healthcare professionals are the ones completing these. You may find that they are great partners in helping to identify what your specific healthcare needs are as an IBD patient. But patients often have to take this task as well, as you're hearing in these patient stories, or you'll see on our website these patient stories. So I encourage you all to go to our search tool on our Crohn's Colitis Foundation.org website and type in appeal letters, and you'll see a plethora of different letters that we have templates for. If nothing else, as part of your takeaways for this segment, I do want to stress the importance of just picking up the phone or just typing up an email and sending us a request for help. The IBD Help Center is a wonderful resource that provides information, guidance, and support to our patients and community. We often refer to local support groups, education programs, but related to this specific topic, we also know what's on our website and can help you navigate to those resources. If you need help with appealing denials or any other needs as it relates to access, we partner very closely with our advocacy team, and we also have many resources and partners that we know can assist in many different ways. Please reach out to us. We are available by phone and by email. And we also have an answer chat available as well. We offer help in 170 different languages. I can say that the Help Center does receive so many questions around how to appeal a denial, or just questions on how to access and cover costs of certain medications, procedures, et cetera. And so the Help Center is able to navigate patients to the right tools that they may need to be able to appeal and advocate for their needs. We are available Monday through Friday, 9 a.m. to 5 p.m. Eastern Standard Time, and our phone number is 1-888-MY-GUT-PAIN. We also are available via email, info@Crohn'sColitisFoundation.org. And programs such as this can also be available on a regular basis. We have a growing library of webinars and archived programs that you can listen to, go back to, also participate live in. So just to learn more about inflammatory bowel disease, Crohn's disease, ulcerative colitis, we really encourage you to take part in our in-person education programs that are happening throughout the country, and you can find one that may be in your local area. We also have regular virtual webinars that are hosted by our team that cover different topics, not just access to care and financial management, but many different topics that I think are important for you all to stay abreast on and updated on. And again, just referencing that on-demand content library. So there's a QR code on the screen. Check that out. It'll take you to our page, and you can find and browse information that might be of interest to you if you ever have questions about inflammatory bowel disease or other topic areas. I want to also encourage you all to download our educational materials as well, ensuring that you're staying informed. Many of these topic areas, as you see listed here, our brochures do cover areas related to how to afford costs of care and how to navigate and what resources are available for you. So please do check that out as well. And with that, I've concluded my program. Thank you so much.
Thank you, Catherine, for those helpful resources. Now I'd like to introduce Erin McKeown, Associate Director for Federal Advocacy at the Crohn's and Colitis Foundation. Erin will share what the foundation is working on at the advocacy level to address these insurance denial issues. Thank you, Erin.
Yes, hello all. I'm Erin McKeown. I am the Associate Director of Federal Advocacy for the Crohn's and Colitis Foundation. In this position, I handle communications with Congress and with the Department of Health and Human Services, as well as the FDA and CDC. But what I'm here to talk to you about today is claims denials and what's going on out there in the market and how it's being addressed by policymakers here in DC. One of the largest players that is causing problems with the coverage of IBD medications and healthcare delivery are what's being done by pharmacy benefit managers, known as PBMs in DC parliaments. These were originally designed back in the day to be group purchasing organizations where individual entities, either insurance companies or businesses, could group together and buy pharmaceuticals at a discount price using their market power to secure lower prices for medications. Recently, there have been a great number of mergers within the PBM industry, and we are now at the point where just 3 PBMs, Express Scripts, CVS, Caremark, and Optum Rx, which all happen to be owned by insurance companies, control 80% of the market for all of the medications dispensed in the United States. And these have grown so large that they are able to act as oligopolies, meaning they constrict trade and are able to keep prices high in some instances, while also denying care. They're continually coming up with new ways to either delay or deny care. And this is actually a process known as utilization management. If we go to the next slide. Part of the problem here is that these PBMs have grown so large, so fast that the regulators have not kept up. And there is currently very little oversight of the PBMs. As they exist right now, they have nobody to answer to but their own shareholders. These are privately owned entities. They don't have to answer to patients. They don't have to answer to health plans or insurers or to the government payers. They are in business to increase their own bottom line. The way that these PBMs make money is by really subverting the way the market is supposed to work. Most of them, when they're being contracted by an insurance company, will say, I will promise you that I will deliver X percentage of rebates on the drugs that you are going to have to end up covering. And they tout these rebates as the reason why they are good at their jobs. This has prompted pharmaceutical manufacturers to keep the prices of medications artificially high, keep the list price high, so that then when they deal with the PBMs, they can offer a lower price, the rebated price, and the spread in between the two looks great. Some of that is passed along to the insurer, but some is not. Some is kept by the PBM. What this does is encourages PBMs. In some cases, we specifically see these with biologics that have biosimilar competitors. What they will do is actually the PBM wants the higher cost medication because they get the better rebates and they're keeping that rebate. This is diverting the way the market is supposed to work. They also do steer patients to their own pharmacies. If you've been told that you can't fill a medication at CVS, but you have to go somewhere else or you have to get it through a mail order, that's because your PBM has a relationship with that pharmacy and they're sharing in the profits. And the third is utilization management. And this is just different, unique, sometimes very creative ways to delay patients' access to either their needed tests, their supplies, or their medications. These are things, what I'm going to talk about in a short while, things like prior authorization, step therapy. All of these are done just so that the PBM doesn't have to pay out funds for medications as quickly as they should. It's really what it comes down to. Now, this has become a very hot topic on Capitol Hill. It has come to members of Congress' attention that, first of all, Medicare and Medicaid are getting very bad deals through these PBMs, and the federal government is paying more than it should for medications that are covered by these programs. And actually, as we're taping this program right now, the Energy and Commerce Committee in the U.S. Capitol is holding a hearing on PBM reform, where they're talking about things such as rebate pass-through, saying that any rebate that comes to a PBM must be passed through to the insurer and then to the individual patients in terms of the premiums that they pay for their insurance, and that the PBMs can't just hold on to those. They're also talking about transparency. They want the PBMs to just show why they make the decisions they make, why they put certain medicines on certain tiers above or below others. Is that because this particular medicine has a great rebate and the PBM is getting a cut of that? Or is it actually based on medical guidelines? And we're also talking about on the Hill, changing the business models of PBMs so that they're no longer paid according to the rebates that they negotiate, but that they're paid on a flat fee schedule for every product that they negotiate, a flat schedule that's not dependent upon what they actually pay to the PBM. And this is particularly important when we're talking about Medicare patients. Patients in Medicare often have a hard time going from private insurance to Medicare because their copay, 20% generally in the Part D program, is based on the list price, the higher price that almost nobody pays except for Medicare patients. And this is compounded by the fact that Medicare does not allow patients to use copay assistance because they see it as an unfair inducement to trade, meaning that they think it's a kickback to the patient if they receive copay assistance from manufacturers. It's a large problem in the Medicare population that we're trying to address through PBM reform. Can I go to the next slide, please? Here, this is about prior authorizations. One of the ways that PBMs are trying to drive down the utilization of healthcare. This is when your insurance says that it will not, you cannot have access to either a procedure, it could be a colonoscopy, it could be an endoscopy, or supplies or a medication until they review it, the request, and approve it. This is called prior authorization or prior approval. It's a growing problem. Very many new drugs are being placed in prior authorization programs now. It's actually grown from 35% of IBD medications in 12 years ago to 67% now, and the numbers keep increasing. This is, we're told by GI docs, this is a leading cause of therapy abandonment, that when people are denied their prior authorization, they just give up. They walk away. They decide they'll try some other treatment. They don't fight. And this is really a shame, because when patients do act like the bulldog, go out there and appeal these, 97% of prior authorization denials are ultimately overturned. You just have to put the effort in, hopefully with the help of your doctor, in filing the appeal and showing why this procedure or medication is required because of your condition. And we're seeing a lot more interest in Capitol Hill on abuses of prior authorization right now. A lot of this is tied to the use of artificial intelligence and the fact that insurers are using computers to just deny batches of hundreds of claims at a time, set up. If they don't meet the algorithm that's been placed into a computer, they do not look at a patient's record. There wouldn't be time. You're doing 300 in a minute. They're not reviewing your medical record. They're just clicking off, this didn't hit the right button, so we're going to deny it. We are right now working with the Congressional Crohn's and Colitis Caucus on Capitol Hill to launch investigations into the use of artificial intelligence in claims denials. Another thing, can we go to the next slide, please? That we have been addressing for years. I've counted it 7+ years here at the federal level, trying to address abuses of step therapy. Step therapy occurs when a patient is prescribed a particular medication, let's say it's Remicade, but their insurer comes back and says, we will not grant you access to that prescription that your doctor thinks is the best for you unless you try and fail on our preferred, almost always less expensive and less effective treatment first. I've heard outrageous stories where insurers have said, well, you don't really need a biologic. We think you should try on ibuprofen first and show me that your condition doesn't get better on ibuprofen. And then oftentimes they add in yet another layer. Then they'll say, all right, ibuprofen didn't work. Now we want you to use steroids. And then you try steroids and they don't work. And then eventually you arrive at receiving the medication that your physician already knew was going to be best for you. If you've gone through these kinds of steps, you have been a victim of step therapy. It's the most common form of utilization management out there right now that the PBMs are using. And the real problem is when this is abused, it just delays care. And when you're talking a chronic progressive disease such as IBD, that delay can cause irreversible damage that ultimately costs the insurer more money. But when you're the PBM, you don't care about what's getting paid in the hospital. That's coming out of the medical benefit, not out of the money that's in your pocket. They're not necessarily thinking rationally about this. Can we go to the next slide, please? We have, as I said, for 7+ years, been working on the Safe Step Act. It has right now been passed in 37 states, which is fabulous. If you're a patient in any one of those 37 states and you are enrolled in a state regulated plan, then you have protection from step therapy, such as what I'm about to describe at the federal level. The reason why we keep trying to address this through the federal government is because the vast majority of patients are not in state regulated plans. That only reaches about 10% of the market. Those would be people who work for a state government or a local government or for the public schools. Largely, you're talking about state regulated plans. Everything else is regulated by the federal government. So we are working here on the Safe Step Act, which outlines 5 different circumstances where a patient should be automatically exempted from step therapy protocols. Common sense things like you've tried the insurer preferred medication already and failed on it, so you know it's not going to work, or that your physician attests that your condition would greatly deteriorate if you're made to wait, or if you're stable on your current medication. Then these are the types of scenarios where you can request an exemption, and the insurance company must get back to you within 72 hours in normal circumstances, or 24 hours in the case of an emergency. Really what we're trying to do, it seems common sense to me, is make sure that there are common sense curbs put around the use of step therapy. What's very exciting this year on PBM reform legislation that has already been passed out of committee in the Senate, and we hope will be voted on in the full Senate soon, does include our Safe Step Act. So we've managed to get it approved in the Senate, and we are working right now to convince the House of Representatives that they should agree with the Senate in including step therapy reform in pharmacy benefit manager reform legislation. So stay tuned, join our advocacy network, and we will provide you with information as this process moves forward and help get you involved in making sure that this finally does get passed in Congress. Can we go to the next slide? The next interesting thing that PBMs are doing, and I find this just infuriating, are the use of copay accumulators. Because so many of the medications that patients use, specifically IBD patients, we are poster children for this, are so expensive, and so many plans require patients either to meet high deductibles or to pay high co-insurance or co-payments that those patients can't afford. These patients often go to the pharmaceutical manufacturers that make the medications and apply for assistance. This can come in the form of a coupon, a credit card, or other ways that the foundations run by the pharmaceutical manufacturers help patients meet their out-of-pocket requirements. What the PBMs are doing now is they're taking this money through the patients that comes from the assistance program, putting that in their pocket, and then turning around and looking at the patient and saying, well, that didn't come from you. We know that came from somebody else, and now you have to pay it all over again. Now you have to meet your deductible again. You have to meet your copay or your co-insurance again, even though this money has already gone into their pockets. When they do this, it's called a copay accumulator because the PBM gets paid twice. They accumulate the funds from the assistance program and then from the patient. And often it's a very rude surprise to the patient. You're going to go, let's say, pick up at the pharmacy counter your medication, and you know that you've met your deductible. You're a couple months into the year, you think everything's good, you've met your deductible, this isn't going to cost you anything, and no, boom, now you have to meet the deductible all over again. And this leads too often to patient abandonment of their medications, which then ultimately leads to a progression in disease. We know these are endemic out in the market right now. 83% of patients are in plans that use accumulators. And really, these are harming the most fragile amongst us. We know that 69% of the patients who receive assistance through copay assistance programs are earning less than $40,000 a year and are in no shape or way able to cover the copayments that their insurance is requiring. Can we go to the next slide, please? So we have been working very hard at trying to pass legislation at the federal level, specifically the Help Copays Act, to outlaw the use of accumulators. This, unfortunately, has been scored by the Congress as costing a lot of money. It would cost the federal government roughly $10 billion over 10 years. And this is making it very hard to move the legislation in this current Congress, which is not interested in spending additional money on just about anything. But we did get a great surprise recently when a DC court, a local court here in DC, struck down a provision in the Health and Human Services regulations covering insurers, stating that accumulators could be used widely in the market. Prior to this, in 2020, the only medications that could be subjected to accumulators were small molecule drugs that had a generic competition on the market. So basically, these are drugs where the patient is choosing to take the brand instead of the generic and not biologics at all. This was overturned and reinterpreted in 2021 by the administration in the office then, which removed that requirement and said that these accumulators could be placed on any medication out there. At the time, that administration said they didn't think that accumulators would be used widely, so it wouldn't really be a problem. And we know that this is not, in fact, the case. 83% of the insurance market is subjected to accumulators. It was great news that the federal government, the DC court, shut down this reinterpretation of the rules, said HHS was wrong in what they did in 2021, that they could not interpret law that way, and instead that it has to go back to the way things were in 2020, which is great. And theoretically, right now, as of September 27th, I think it was, accumulators are illegal and they are not supposed to be used in the market out there at all. Unfortunately, HHS appealed the decision that was made in the DC Circuit Court, and they're going up to the Court of Appeals. This appeal is expected to take at least a year to wind its way through the court system. We are working with many other patient organizations in supporting the DC Court's original read that HHS had to overturn the accumulators, and we will be signing on to amicus briefs and other legal proceedings. In the interim, the Department of Health and Human Services has also asked for a clarification from the court about whether or not accumulators can be used in the market as this case winds its way through the courts. This decision will be likely made in January, and we're fairly confident that we will win here, that accumulators will not be used. They will be put on stay in legal parlance as this case makes its way through the courts, which means hopefully through the vast majority of 2024, patients will no longer have to worry about copay accumulators. But stay tuned. We will let you know how things develop. And with that, I think I'll toss it back to Carrie.
Great. Well, thank you so much, Erin. And I just want to go back to something you were talking about a little bit earlier in your presentation. We've heard that the vast majority of prior approval denials are overturned on appeal. So can you share from your perspective, why then do insurers make so many denials to begin with?
They're just counting on people not to appeal it. They think that if we tell you no, you're going to turn around and either abandon this treatment or try something that they will approve, which is the whole reason why we're saying you put the effort in to actually appealing these denials. And as this is going on, there's that space of time where the insurance company, the PBM, are not paying for that medication. Let's say it takes 3 months for you to get the denial overturned. That's 3 months they're not paying for, Remicade or Humira. And in their minds, that's saving money.
All right. Well, I know we have a lot of advocacy work to do on this issue. So Erin, can you talk just a little bit more about how patients and caregivers can get involved to support these advocacy efforts?
Yes. this is the best thing. We are always looking for new patient advocates. You should know, I go up and I talk to members of Congress and their staff all the time, but what they don't really want to hear from me, they want to hear from patients in their own home districts who have experienced the problems that I'm talking to them about. It really brings home the fact that we're not making this up over in the Crohn's and Colitis Foundation. These are real problems affecting real people and people who are their constituents. You, the patient, are the most powerful advocate out there. And we also want to learn from you what you hear when you're talking to your legislators, what's going on in your lives, what are the things that you're finding to be problems, so we can make sure that we are addressing the proper problems. What you can do is go to the Crohn's and Colitis website, go crohnscolitisfoundation.org/advocacy. We'll bring you straight into our advocacy network where you can sign up to receive updates on what we're doing. And also we will let you know when important legislation or sometimes insurance companies and the programs they're putting forth are under review, and when it would be a great time for you to get involved.
Great. Yes, thank you again, Erin. And yes, I agree. Please join our advocacy network. We're always looking for patient volunteers to get involved, patients and caregivers, family members. We need all the voices we can get, so please join us. And thank you again to all of today's patient and caregiver speakers, Ava, Sherry, and Scott. We hope those of you who tuned in today found these resources helpful. And thanks again to Takeda and Janssen for supporting today's panel. Please visit our website at crohnscolitisfoundation.org to access some of the resources discussed today. And again, I'll say it one more time, don't forget to join our advocacy network at crohnscolitisfoundation.org/advocacy to be a part of these advocacy efforts. Thank you.